breaking barriers and bridging the gaps between patients and doctors. Welcome to Brainstorming with the Docs and your co-hosts, Dr. Glenn Harrison and Dr. Kolby Condos.
All right, everyone, welcome back to this week's episode of Brainstorming with the Docs. I'm Dr. Kolby Condos, my co-host, Dr. Glenn Harrison. What's going on, my man?
I'm all set for this one. It's been a good day. It's been a good day. How about yours? I know you had some company down, you had some family, were you cooking as well?
Oh yeah. I mean, that's my wife's family's whole thing, right? Is they're like a big foodie family. So there's got to be a giant meal at least once a week. And especially if there's company, then you're definitely going to show out. I think that my father-in-law pulled out like maybe 27 pounds of beef at one point.
So there's maybe a few extra pounds on the ankles now.
Oh yeah, definitely. For sure.
That might be a little bit of weight bearing exercises.
You got it. It's a nice segue. God, you're just so good at creating those, you know? So today in Brainstorming, we're going to be talking about something that affects a lot of people, a very diverse demographic, but more specifically females, and that is osteoporosis. If this is your first time listening or watching the podcast or on YouTube and you got value out of the content, make sure you turn on notifications, hit like and subscribe, and stay tuned because we're going to continue to roll out content each and every week, and you never know when we might roll out something that's applicable to you. So without further ado, let's get on osteoporosis, buddy.
Yes, osteoporosis, osteopenia. These terms are used interchangeably, but so we don't get too far in the weeds. Osteopenia is kind of like an early stage. That's the way I explain it. Is that the way you explain it?
Yeah, it's like a precursor to osteoporosis, right? So you get one and then you get the other, unless you do something about it.
That's right. Yeah. So why is it so important? Well, I think there's certain populations like thin Caucasian females. That's the way I always say it. It's not a concern till it's a concern.
Right.
You don't see younger females concerned about this till they go to the doctor, and then there's all this bad news, and then there's panic mode. And then once there's a panic mode, well, it's pretty hard to make too much ground with it if I try to tiptoe around it. It's true though.
Yep, absolutely. So really important, because if you're suffering from osteopenia or osteoporosis, what it is it's actually a gradual decrease in your bone density, and your bones become fragile. So they're more likely to burst in your spine. You can get a burst fracture. It can be in the long bones too as well. And you can suffer from fractures. This is when you see, older females that trip and fall and they break a hip or something like that. It's actually the most common in the spine, but it can affect all of the bones, depending on the severity of it.
That's right. Yeah. I've seen ribs and then sometimes people have a fracture. And if I see it, it's a higher risk individual, a thinner Caucasian female. I'm concerned after the age of 30, was the trauma a good reason for that type of fracture? And if it wasn't, we got to start asking questions about bone density, because the worst thing is it's not considered early enough. And then there's another fracture. I've had patients where they were scared to do physical activity, and they were only in their mid 50s because they were worried about another fracture, another break, because of their bone density concerns. So,
which is not necessarily a good thing either, because weight bearing exercise is actually one of the ways that you remodify your bone, and it actually makes it harder. So it's kind of counterproductive when you're not exercising, you're not doing weight bearing, or you're doing something like pool therapy instead of resistance training and weight bearing exercise, because you're not actually getting the therapeutic benefit of the weight bearing activity to remodify the bone and make it harder.
That's exactly right. So there's a place for these things, but let's jump into a little bit. There's from what I know, when we're looking into this, there's really three major types of osteoporosis. There's, postmenopausal, vitamin D deficiency. That can be a thing. It's not that common. I don't know. Have you ever seen that clinically?
I always run vitamin D on pretty much all my patients, but I've, and there's usually more than one cause. If you do end up finding osteoporosis, it's usually more than one of these things.
And even sometimes medications that play with parathyroid gland, that can be a problem. Steroids. Right.
Yeah.
That's a big one. People are on steroid, women or men, but mostly women, again, are higher risk of all of this. I always tell people that two major causes for, bone density is, or the ways to, work against it is enhanced absorption, digestion, and then again, get back to that weight bearing exercise. So those are, what about prevalence? I know that was kind of shocking when we looked at these numbers.
Yeah. I mean, females 1 in every 3, males 1 in every 8, affects females disproportionately. So 4 to 1
versus men.
Yep. Yeah. To men. And then again, like you said, you're Caucasians and Asians actually, which I think that we learn in school, but we kind of gloss over.
Forget. Yeah. Well, depending on what population we're serving as well.
Yeah.
And then, if someone's concerned about it, if someone's listening to this, they probably have had a diagnosis or family or something, right? You don't think about osteoporosis or osteopenia unless someone throwing those names around you. But some of the trauma fractures that shouldn't happen. I guess that's a big thing if it's just off the cuff, and a person shouldn't, female, I'm not, 50, or I've seen osteopenia at 30 years old. I've seen that. Maybe you have in your clinic as well.
Yeah. Yep. I have.
And I always like to talk about, bones is acting as a calcium bank account. So you want to invest in it when you're young. That's when you're investing in it. And then as you get older, you start withdrawing from it. So you don't want to start trying to save up later on in life. You really, really want to maximize the bone density earlier in life. And if there is a sign or a symptom younger in life, we'll catch it early so you can start preserving and maintaining. That's easy.
Putting some money in the savings account, right?
Yeah, exactly. But as you said, vertebrae, hip is a common one. A lot of times people will fall, and it's the result of the hip already being broken, and that's what creates the fall. It's not the fall creating the break.
Yep.
Right.
Yeah.
And then wrists. I didn't know about that. Have you ever seen wrist fractures due to bone density issues?
At least not directly. I've seen people that have broken their wrist secondary to osteoporosis or osteopenia, but I've never been the one that caught it. I have, however, caught like burst fractures in the vertebrae from osteopenia. And actually, I caught one a couple weeks ago where the patient came in with like really acute low back pain, and it was from picking up like, an infant, so less than 15 pounds. And that's what caused the fracture in the vertebrae.
Just flexing forward, putting pressure on the front side or the anterior side of the vertebrae. Yeah. Wow. Well, I've seen it. Maybe you've seen it. I've seen sneezing.
Oh yeah.
Sneezing fracture ribs all the time, especially when there's bone density problems.
Yeah.
Yeah.
Yep.
Coughing. Really.
Anytime
really
you increase intrathecal pressure, then which is like increased pressure in the abdomen, you can do it. Anytime you like add a load that's off center, like an axial load that's off center, so lifting anything, you can cause burst fractures, falls. If you already if you're already suffering from osteopenia, you need to get on top of it, because it can happen very easily and it can happen really quickly.
That's right. That's exactly right. So what are some risk factors? I know we talked about, again, picking on thin Caucasian females or Asian females, higher risk factors, but what are some other risk factors that you see?
Yeah. So, I mean, obviously, if you have a family history of it, you're going to want to be, if your mother or your sister or whatever has osteopenia or osteoporosis, you're going to want to be really diligent about making sure that you're getting checked. Early onset menopause, so people who go through menopause in their late 40s, early 50s. Smoking is a really big one, actually, that people don't normally associate with osteopenia or osteoporosis, but it can definitely contribute. Alcohol use, and again, like we talked about, like people who aren't really active as far as like resistance training or weight bearing exercise. And then anytime you have like a thyroid, or not a thyroid, a hormone issue, so any issues with the parathyroid gland
or estrogen,
like
but
estrogen,
that estrogen piece is if there's an early onset menopause, so there's not enough estrogen to maintain those high levels of required bone density earlier in life.
Right. So if you suspect that you have osteoporosis or osteopenia, what are the steps that you go through to try to make sure that it's caught?
Well, I guess the gold standard in my world, and I think any of the research, is a DEXA scan, a bone density scan, where they take a picture and then they evaluate it. And then there's different DEXA scans. I don't know how familiar you are with those, Dr. Kolby, but there's some that'll do DEXA scans on certain areas of the body. And there's, more than just one section. I know a lot of times the hip they like to do, but then there's DEXA scans. They'll focus on other areas of the body as well.
Yeah, we played around with them a little bit in like undergrad when I was in a biomechanics lab, actually. And they could do like the whole body, which is that's a good way of showing like areas that are under high amounts of stress actually will remodify.
That's
because
right.
we did like a study on various athletes and
Okay.
what their bone density was in certain joints.
Different
And it was really,
athletes would have
yeah.
more bone density in different places.
Yeah. So like,
Depending.
offensive linemen, obviously you're going to have more density in their knees. One thing I thought was really interesting was we did like competitive cyclists, and where would you think it is the most density?
I don't know, glutes.
It's in their wrist, because their wrists are always taking that constant micro trauma from hitting like bumps in the road.
Wow.
Yeah, it was really interesting. So
Wow.
that's
Well, that kind of tells us what some kind of therapies could be used for then, right? Even
right.
vibration
Absolutely.
therapies to some
Yeah.
extent. But yeah, don't underestimate anybody who's listening to this. Don't underestimate the power of weight bearing exercises. I don't know the numbers, and I wish I did coming into this podcast, but when astronauts go up into space,
Mhm.
they and even the men, they're constantly training, trying to enhance as much bone density as they can for months and months and months prior to going up in space, because there's no gravity, and they lose significant bone density just not having gravity.
Right.
So our bodies need these compressive forces, these
Yes.
weight-bearing activities, even if it's a big meal at dinner time and we put on a couple extra pounds walking.
Even if
away
I'm
from
curling 27 pounds of beef steak to your mouth.
Yeah, exactly. So the DEXA scan. Another interesting thing I learned about the DEXA scan is from one machine to another, they're not quite measuring apples to apples. So if you go for a DEXA scan, you should probably try to get that same machine the next time you go, because they're all calibrated a little bit differently. So there can be some variance. And if you're looking at maintaining, you're literally looking for percentages. If it's a different machine, you might not have the same calibration from one machine to another. So I always tell people, if I send them to an imaging center, we find out the exact machine, and we get them to do that same machine, a year later or 6 months later, whatever the strategy is. So that's so DEXA scan. I think X-rays are able to catch a little bit of it. You probably,
yeah, if it's pretty
X-rays.
advanced, if it's advanced, then it'll catch it. You can go, the bone looks like it's lost some of its density, but it's got to be pretty far advanced, I would say. I'd say DEXA is probably the gold standard as far as like getting really concrete data on where you're.
Yeah. So I think if a person is concerned, just talking to your primary or whoever, and getting a bone density scan. Don't wait till the insurance model says, oh, you need a bone density scan after an X number of years, 65 or whatever insurance it is and whatever number it is. If you do fall into any of these risk factors, corticosteroid use, thin Caucasian females or Asian females, history of smoking, familial history, don't wait. Just go take it. It's non-invasive. Just go take the picture, and then and at least you have a baseline. You have a baseline and know where you're at. So what are after diagnosing, what are some of the management strategies?
Well, I mean, you obviously have to determine the cause,
Right. There is a cause.
Right. Assess the hormone status. You can do a hormone panel. Vitamins, obviously, if you're deficient in D, that's a really simple, cheap.
Just to interject there, we were I remember before we started, we were ranting about calcium.
Yeah.
Do you want to rant a little more about calcium?
I'm going to leave it to you.
Okay. It is okay. I'm going to do this. Calcium is absolutely madness. What people say that nowadays that there's all sorts of different providers, and from both sides of the line, the natural doctors, the medical doctors, everybody's throwing calcium at people that are concerned about bone density, or drink more milk. Why milk? There's a fraction of calcium in milk versus certain leafy green vegetables.
Mm-hmm.
So now they throw all this calcium at people that they can't even absorb, and there's blood calcium and bone calcium. Just because you take more supplement calcium, you might bring up your blood calcium a little bit, but it's not necessarily going to translate into bone calcium, because the hormones is too dynamic for all of this. So calcium is a joke when it comes to bone. I'm saying it. Calcium is a joke when it comes to bone.
Well, if you're going to take it, you better make sure that you're absorbing it and converting it. Right.
That's another thing. Yeah, that's another thing. And if you don't eat any leafy green vegetables, well, there's got to be some kind of calcium coming into your diet. So yeah, calcium supplementation is a joke for bone density if you are eating real food.
Yes.
And you can absorb it. But what you mentioned, vitamin D, is much, much more powerful than calcium ever could be for bone density.
Yeah.
And it's not an opinion. It's in the research.
No, that's what it all shows. And we can go deeper into this hormone stuff, but it's just, there's really no need. You can just take our word for it.
That's right. But we did a podcast on hormones too.
Yep.
So
if you have a lot of questions on it, then feel free to reach out to us.
Ultimately, they should be evaluated, and also especially they should be evaluated or considered if, again, as you mentioned, Dr. Kolby, early onset menopause. That's something.
So then, we got the hormones, we got the vitamins. Obviously, we've beat over and over again, but we'll say it one more time just for the sake of being thorough. Weight-bearing exercise and physical activity, those compressive forces that has gravity into the equation. So doing things like pool therapy is great, right? But it's not going to help you with osteoporosis.
That's right. Yeah. So weight-bearing exercises, walking, anything with impact within reason. So we're not breaking anything. Someone is worried about fracturing bones. Well, we don't want them to run initially. Want them to walk. Want them to, even or resistance training with someone that's watching and inspecting, making sure form is proper. But weight resistance training is like gold standard.
Yeah,
gold standard with this. So. So those are very, very powerful. And if you're going on a trip to the moon, because now it's a thing at this point in time, billionaires are going up, probably want to do a lot of weight bearing exercises before you go up.
Yes, you would.
and then another thing I know you're probably going to touch on was digestive health.
Yes, absolutely. It doesn't matter what you're taking or what you're eating if you're not absorbing it, right?
That's exactly right. And I've seen so many women, a decades long history of digestive problems. And they don't look like a candidate for bone density issues. And then we find out. And we're like, wow, how much did digestion play into this? Yeah. And of course, there's, medical management strategies as well. And I think when cases get very, very severe, there has to be a very, very aggressive effort. And there's some pretty interesting medications out there. Do they have side effects? Every medication has 7 to 14 side effects, severe side effects. But there is a place for these things. So
yeah, if it's bad enough, you bet.
Definitely do that. And just because you're using a medication or your doctor prescribes you medication,
doesn't mean you can't use the other avenues,
this other stuff. Yeah, that's a short-term effort. Doesn't mean you can't do the long-term piece as well. So, yeah. Well, I think we kind of beat that up.
Yeah, it was kind of short, sweet, and to the point, but if you got value out of this podcast or this YouTube video today and you like what you're hearing and seeing, then again, hit like and subscribe and turn on notifications and stay tuned because we're going to keep rolling out new information and you never know when that might be applicable to you. So till next time.
That sounds good, Dr. Kolby. Yeah, in case you're going to the moon, well, you know what to do now, right?
You got it.
Have more beef. Have more beef.
All the beefs. All right, buddy.
Okay, bye-bye.
Bye.